So Bill, it seemed to me that the initial adoption rate after Ibrance approval was kind of low. And you had two things I think that may have affected it. And one is the everolimus story preceding it. And I think the question is are these just drugs that overcome hormone resistance and therefore don't have innate activity? And the second being that I think there was a general perception that hormone receptor positive patients maybe do better than they actually did. And I think in the original first Ibrance trial that led to approval, the PFS was only 10 months in the non-experimental arm. And I think that when I was often doing more general kind of market research among oncologists, they saw the hormone receptor positive population as the good patients, the patients who were going to get a prolonged response. And I often actually did polling to look at things like, what does that mean? And they would think, often get response like 2 years of control with initial first line intervention. But I'm curious about the slow uptake. And then now it seems that that adoption rate is very, very high. So if you could comment on that, what your thoughts are.
Yeah, I think it's probably multifactorial. I think that when the CDK4/6 inhibitors were first introduced, probably the everolimus experience colored things a little bit because you had this perception that endocrine therapy is largely well tolerated. Patients go on about their life, nothing bothers them, everything's good, and then you add another agent. And in the case of everolimus, maybe some patients had stomatitis, they had other side effects, and suddenly endocrine therapy wasn't so friendly. And then with the CDK4/6 inhibitors, there was this concern, perhaps shared by some, that if you added a CD4/6 inhibitor, that you're adding a chemotherapy light agent to endocrine therapy. Now you're dealing with low blood counts, and you're basically, just adding chemotherapy to endocrine therapy. So I think there was this false impression that you were changing the way that patients were experiencing their therapy, or that they couldn't be compliant, or some other variety of issues. But I think what happened over time is there was a realization generally, and I know we'll come to this, is that the CD4/6 inhibitor side effect profile for the most part is pretty well tolerated by patients. And I think once there was a more broad appreciation of the uptick in PFS, a dramatic improvement, that the uptake of the drug class was, expanded. And I think most people now, regardless of which CDK4/6 inhibitor you use, find that the side effects are pretty manageable. And for the most part, most patients do pretty well. And you can't dismiss the marked improvement in PFS that patients are experiencing.
Thanks. Joyce, in selecting patients who are appropriate, we've already addressed that issue of visceral crisis, but we have other factors. And one of those factors, of course, is the extent to which they had prior adjuvant therapy with chemotherapy, and the extent of their prior neutropenia, prior adjuvant therapy with hormonal agents, and what do you then do, duration of time, either off therapy or duration of benefit from the prior adjuvant. So if you could kind of build out that branching tree of how you approach those patients for CDK4/6 therapy, and who's eligible, who's not, and then which of the partner endocrine agents you're using based on that history. That would be helpful to kind of get a sense of how an expert approaches this.
Pretty much I and everybody goes by the actual eligibility criteria for the pivotal trials that led to FDA approval. So with regard to pairing one of the CDK4/6 inhibitors with an aromatase inhibitor, patients had to either be de novo metastatic, they had not had any therapy at all for prior breast cancer, or if they had had prior adjuvant endocrine therapy, they had to have completed it and have been off of it at least a year, and then they were eligible for frontline AI plus minus a CDK4/6 inhibitor. If they recurred on adjuvant aromatase inhibitor therapy, whether it be they were on it for 5 years, 8 years, if they recurred on the adjuvant AI, then the AI doesn't make a great deal of sense for them as a therapy. So then those patients were eligible for the fulvestrant plus minus the CDK4/6 inhibitor, the so-called second line trials, although for some it's their first line if they recurred on an adjuvant AI. And patients could also have progressed on an AI in the metastatic setting and then also be eligible for the fulvestrant plus minus CDK4/6 inhibitor trial. So pretty much that's how I and many others will approach, just go by where if you want to get the benefit that you see in these trials on PFS, you really do want to go as closely as you can by the eligibility criteria that were there in the protocol.